All right, good morning, everyone. We are going to finish up with Unit 10. I think we left off on hydrocephalus. Does that sound right?
Yes.
Okay, perfect. All right, so this is a congenital issue. This is something that we notice right after birth. It is something that sometimes can go undetected if it's not a very big issue. The important thing to keep in mind here is that we have two main pathways, two major pathologies of things that are happening here. We either are making too much CSF, we're producing too much CSF, or we have an ineffective method of draining that CSF, okay? Can be a combination of both, but one of those two things leads us to having too much CSF. If you go back to the slide where it talks about the signs of increasing ICP, this is what we're going to see in this patient. So if we see it in that baby, we're going to see that that bulging fontanelle, like we talked about, those prominent scalp veins that you can see in this little picture here. You can see this huge forehead that we see on, I think you can see it better on the picture on the left. That's called frontal bossing. Like your boss at work. And what's happening here is we've got a collection of CSF that's pushing onto that skull right there, okay? The reason that we see hydrocephalus so much more prominently from a visual standpoint in the infant or the newborn is because their skull hasn't, the sutures haven't fused yet. And so we're able to see that movement more freely, all right? Other things that we see, it's not seen in this picture here, but that setting sun sign, this happens in your eyes. So think of the bottom eyelid on your eye is that horizon. And as that pressure gets bigger in here, it pushes those pupils down. The pupil essentially becomes that setting sun sitting right there. So what you see is a lot of white. You see a lot of the cornea, because of all that pressure, it's pushing the pupils down. All right. So think of your eyes as that horizon, that setting sun. And that's what we're talking about. That high-pitched neuro cry that we've talked about, that is very evident here. All of that pressure pushes onto those fragile neurons and really it causes that irritating cry here. If we were to happen, if it, I mean, it is a condition that can develop as a secondary condition. If we're looking at hydrocephalus from a primary condition and we did not catch it in that early newborn infancy period, it could be because the body was able to compensate well enough that it wasn't causing these obvious symptoms, okay? So whether it's that or it's coming as a secondary, there's some other pathology that's causing hydrocephalus. What we see in that older child, they may complain of headache, dizziness, the irritability is still present, but we also see vomiting. Typically, we are going to see the hydrocephalus cues in the infant before they reach the vomiting period, okay? So what are we going to do about it? To confirm the diagnosis, we do that CT and MRI. That's going to show us that we confirmatory have that hydrocephalus. The best course, or the gold standard of treatment, is that VP shunt. So that stands for ventriculo placement of the shunt. All right. It goes about right here. Sometimes you can, there's a couple different ways that they can do this. All right. They can have it with the reservoir. If there's something on the outside that you can see, that means that there's a reservoir. The reservoir is an open area of the CSF that you're able to sample, you can like drain it manually if you need to. If we're putting in a reservoir, this is something that it's usually temporary. We're not going to send the baby home with this open area. Obviously that would be a huge infection risk. Okay. But that VP shunt is what we're seeing here in this picture. The super cool thing about this is that it grows with the child. So it's not something that we have to continue to go back in, but as that child continues to grow, gets longer, this tubing that's in his stomach actually uncoils as he continues to grow. It works a little like peritoneal dialysis, where we have this connection into our stomach, and our stomach is actually where we push that extra CSF, or we help facilitate drainage of that CSF, and then it passes through our digestive system just the way that anything else that went through the stomach would. All right. But I think the coolest factor is that we don't have to go in and do a bunch of additional surgeries as that child gets bigger, because the drain grows with him. Okay. Doesn't mean that it's a perfect system. Obviously, there's always ways for it to go wrong. Biggest risk factor here is infection. Okay. Especially if we're doing that reservoir, we've got that open area. Like I said, that's only in the hospital. If we need to frequently monitor the CSF or something like that. Okay. Once that child goes home, we still have potential for infection, but it's not as high. Okay. What we would see if this malfunctioned, if there was a clot, kink in the tube, or some other reason that it stopped draining, is all of those same signs that we saw at the beginning. All right. So the increasing head circumference, the irritability, the bulging fontanelles, if we still have an early infant, that setting sun sign, all of those signs are going to tell us that this is not, that the VP shunt is not working effectively. Okay. So definitely something that we want to teach our parents. We may also see, we talked about with ICP, trying to keep that pressure down. We want to make sure that our child is having everything essentially balanced. This means that when it comes to potential constipation, that we want to make sure that we're preventing that for them. Obviously, we don't want to give them daily laxatives or anything like that. We don't want anything that the body may learn to depend on and not be able to function on its own. Stool softener, especially in the healing stages of the of that VP shunt, may be very helpful. If the parent is starting to see those early signs of constipation, we want to get them seen by a primary care provider earlier rather than later, so that hopefully we can prevent any malfunction and any return. All right. When we look at the prognosis of hydrocephaly, so how well is this child going to function later in life from a developmental standpoint, it's all in the timing of the diagnosis. The earlier that we can diagnose hydrocephalus, sometimes we can see this in utero. I've actually read about some in utero surgeries that are being done for hydrocephalus now. I don't know how effective they are as putting in that shunt. I think it's more kind of a tapping situation where they just remove some of that CSF off the brain. Once the child comes out, then they can do a more permanent fix. The whole thought process is taking that pressure off the brain so that the brain is able to develop, because cognitive function is a huge potential risk factor here. So if we're seeing this really early in utero, the hope is that we have some way to fix it or to lessen it in utero so that brain is able to develop appropriately in utero, then do something more permanent on the outside. If it's something that develops closer to delivery, then it has less likelihood to have permanent dysfunction on the brain. Okay. To give you an example, I went to high school with a kid who was born with hydrocephalus, and obviously he would have been born in the late 80s when I was, and he actually graduated valedictorian in our class. So there's not a automatic connection that someone born with hydrocephalus is going to have poor developmental or poor cognitive function. It really is all about the timing of that intervention. All right. Your big nursing interventions for this patient, whether it's before surgery or after, is going to be ABCs. Obviously, it always comes back to that, and your neurologic assessment. Okay. Just like we talked about with that increasing CSF, you're going to note those subtle changes as the problem gets worse. Obviously, the hope is that we're able to do our surgical correction before before it gets worse. Okay. All right. The next thing that we're going to talk about is cerebral palsy. Now we are in chapter 49. What I need you to understand about cerebral palsy is the biggest risk factor, the biggest connection that we have to a baby developing CP is prematurity. The other factor, the other big connection is anoxic, so no oxygen during that time of delivery. Okay. Again, we don't automatically know that a baby has CP. We may see some early signs, just like we talked about with some of our other disorders, but from a developmental standpoint, we have to wait until that baby starts missing milestones before we can really make the definitive diagnosis. Okay. So that lack of oxygen, whether it's related to prematurity or related to a delivery complication, is the biggest connection that we have as far as risk factors to this. Okay. The other thing that we have to keep in mind with cerebral palsy, like a lot of these other neurologic disorders that we've talked about, there's a spectrum. Okay. Some babies or children are impacted more heavily or more debilitatingly than other children. All right. There's a huge component of cognitive and developmental function with CP as well. We'll get deeper into that in just a second. Most often we think about some type of physical disability, not being able to walk, effectively on their own. It does attack the voluntary movement. So that can be a big factor there. All right. You can see some of our types are spastic. So these children don't have the capability of really controlling their motor function. These children are likely to be needing some type of assistance when they walk, whether it's through a cane, through braces, or maybe full on, they need to be in a wheelchair because their mobility is that affected. You can see the other component there is development of contractures. So a big focus on this is going to be on this care is going to be about physical therapy, making sure that we're moving those muscles, providing medications that decrease that muscle spasticity. Dyskinetic, we may have that chorea, those uncontrolled movements that sometimes we see with Huntington's disease, for example, or Parkinson's. It's kind of those tics where the child's not controlling the movement. It's just something that happens. Okay. They may also have issues with controlling their movements that they want to control, and speech may be affected as well. And then with ataxic CP, they lack the ability to coordinate their muscles. So there's a lot of variations when it comes to CP, different ways that we can see that present in our child. All right. We're going to diagnose this with the MRI. Like I said, it's hard to diagnose this early in life, but there are some things that we see that kind of lead us to the fact that this may be something that we'll see as that child gets older. All right. That persistent primitive reflex, that Neuro, is a big example. Remember, this should dissipate within the first couple of months. So if we're seeing that continue on past that, we want to think about some type of potential neurologic dysfunction. All right. Stiff, rigid posture of extremities, arching back, pushing away, floppy tone. I mean, some of those could indicate other things. We talked about that arching back with reflux. So we really want to try to get the entire picture before we really slap a label on it. Okay. As far as our milestones, you can see unable to sit supported by 8 months. That ties into that floppy tone. Feeding difficulties could be part of that inability to control our movements. And you see in big letters here, failure to meet milestones may be a red flag. Remember, we have to take everything in the whole picture. It's not just one delayed or missed milestone. We really want to see that pattern there. Okay. Failure to smile by 3 months, lack of interest in surroundings. Again, this is why we need that full picture, because we said that was a potential early sign of autism spectrum disorder as well. Okay. So at the time of diagnosis, typically what we're seeing is that delayed gross motor movement. These children are not meeting those motor milestones. They're not crawling. They're not able to sit up because their muscle tone is not floppy, or is not controlled. They're not able to really work past that low tone. Okay. Alterations in muscle tone could be hyper, could be hypo, depending on what type of CP we may be looking at. Abnormal postures, just in the way that that child is sitting, standing, etc. Again, because he's not able to control his movements. And reflex abnormalities like that Neuro that we already talked about. Okay, when we look at the prognosis of CP, CP is associated with altered learning or reasoning. So again, doesn't automatically say that this child is going to have cognitive dysfunction, but it is often associated with this disorder. Okay, seizures, impaired behavior or interpersonal relationships, sensory impairment such as vision or hearing, all of those can be part of this disorder. Okay. Other issues, of course, like we've talked about, is those musculoskeletal issues where it can be difficult for these children to walk. Luckily, just like we've talked about with Down syndrome or some of these other neurologic disorders, the earlier that we can identify this is what's going on, we can start some type of treatment, and these children are having a much better prognosis than they had in previous decades. Okay, some of our common problems: dental caries, that's a fancy way of saying cavities, constipation, chronic UTI, feeding difficulties. Most of these are related to the control of those movements. All right. Some of these are involuntary functions and some of them are voluntary, but all of that muscle spasticity goes into here on why these things don't work very well. Okay. Again, the earlier we can interact with these children and try to get them some therapies to help their specific situation, the better the prognosis are. Okay. Prognosis also depends on the type and severity, because it is a spectrum disorder where children can be differently affected. Some children naturally are just going to do better, have a better prognosis than others. Timing of the diagnosis is another big factor, earlier rather than later, getting those therapies started, and how aggressive the family and healthcare team are with the interventions. How often are they willing to go to those physical therapy or have physical therapy in their home, whatever it may be. Give them those early educational opportunities to try to catch up or get to their highest level of functioning. Really looks at how far or how well that child's going to do long term. Okay. All right. The next thing we're going to talk about is a category of disorders. These are our neural tube defects. We're going to talk about some of these specifically, but I'm sure you guys remember from talking about the prenatal side of this course, the best thing that we can do to prevent neural tube defects is to provide that folic acid. And if we look at the recommendation, folic acid is recommended for all women of childbearing age, because sometimes women are trying to get pregnant and sometimes it just happens. And our neural tube is developed between 4 to 6 weeks of embryonic development. So it's very early in that development of that fetus. A lot of women don't even know that they're pregnant by 4 to 6 weeks. So the reason that the recommendation is for all women who could get pregnant to take this folic acid is because depending on lifestyles, we may just not know that we are pregnant. Okay. Some of the common neural tube defects that we are going to discuss today, that anencephaly, this means that there's no brain. This is a disorder that's incompatible with life. There's not a way for us to develop a brain or any surgical correction that we can do, but we'll talk more about that one. And then meningocele and myelomeningocele. So we're going to talk about both of those. One of the most common neural tube defects that we see is spina bifida. All right. There's 2 different ways that this can occur. We'll get deeper into that on the other side. When we're talking about neural tube defects, the only connection that we really have is that folic acid. Beyond that, It's really a multifactorial disorder. So women can have been on the folic acid before they got pregnant. They were still taking it when they were pregnant. They did all of the right things, and these are still things that can happen. Sometimes we see them in certain areas. So it could be something that's environmental. Women in that area may have been exposed to some environmental issue, like a pollutant that is in the air or in the water. It could be related to maternal malnutrition. Even if she was taking that folic acid supplement, if she wasn't eating healthily, that's something that can happen. And sometimes the woman can do all of the right things, not be exposed to anything, and it still just happens. All right. This is something, these neural tube defects are something that we can see on ultrasound. If we're looking at a woman who's not getting adequate prenatal care, we may have a woman get, just shows up to labor and delivery and it starts to give birth, and we don't realize until in that moment. All right. What the goal is when a woman comes in without prenatal care, we don't have access to her records. They try to get an ultrasound done before, but depending on what stage of labor she came in, that may not be possible. Okay. So hopefully we diagnosed it prenatally so that we can take the proper precautions. The best case scenario for these babies is that they're born by C-section so that we can protect that sac. Okay. So let me show you a picture just in case you're not familiar. What we're looking at this picture, this is spina bifida cystica. Okay, this means that there is a visible sac on the back where we can see some part of our insides. Okay. We likely have some nerve fibers in here. There's CSF in here. But our goal for the baby that's born with spina bifida cystica or some type of defect that we can visually see is to protect that sac at all costs. Okay. I don't know if you can see it in the picture. It kind of, if you look right here in the middle, there's kind of a glare off the middle. What you're seeing is the reflection of that sac. Okay. So this is going to be a very thin membrane. What we want to do here is keep this patient prone. All right. Keep him on his belly. No pressure on that sac. We want to keep that sac moist. We're going to do that with wet gauze soaked with warm saline. Thermoregulation is going to be a huge issue for this kid. So we want to put him, because we have to keep him naked, we have to keep him prone. He's going to be in a radiant warmer, meaning that we're going to have an external heat source coming down on him. Okay. We want to encourage parental bonding, but holding this baby is not going to be possible until after surgery. So we're going to teach some of those things that we talked about in our first week together, those the bonding through like containment, gentle touches, that kind of thing. Okay. We're not going to diaper this baby because that's potential risk for putting pressure on that sac. You can see, I don't know if you can see, but underneath him, he has a diaper. So there's a diaper protecting his linens and trying to keep everything from getting completely covered in whatever bowel movement or whatever movement he may have. But we're not going to actually close it. We need to keep everything open so we can see what's going on. All right. No rectal temperatures, as that could potentially burst that sac or put pressure from the inside, causing other problems. Okay. So what you need to take away from this is protecting the integrity of that sac is essential before surgery. So we're going to do all those things to make sure that that happens. What we're seeing in this picture is spina bifida cystica. There's another type of spina bifida called spina bifida occulta. That essentially just means that it's hidden. There's no visible sac. We have to look more closely for some subtle signs. What we would see in occulta, we may not catch this in utero. This is something that we would see in utero on that ultrasound if we're getting adequate prenatal care. But with that occulta, where there's no visible sac, it may be something as subtle as a lipoma, so a fatty patch right there at the base of the spine. All right. We may see a depression or a skin dimple right there in that same area. Dark tufts of hair, especially in kind of a whorl formation, can be some red flags that we need to do an MRI of that area to see if that's what we're going on. Okay, like the meningoceles that we'll talk about in just a second, the higher the defect, the more inclusion of our nerve fibers, of our spinal cord, etc., the more likely we are to have long-term effects. Okay, so if we look at living with spina bifida, some of our complications include bowel and bladder incontinence. That's related to where that defect was. Sometimes with surgical correction, we can correct that. Sometimes we cannot. All right. Musculoskeletal issues may be a factor as well. We may have children that can never walk with spina bifida. Again, just like these other conditions, there's a spectrum of how deep the effects are. If we're able to correct that. And it also has a factor of how early in development it occurred, if it affected the development that should have come after. Okay. The bladder incontinence is often tied to what we call a neurogenic bladder, which means that the bladder does everything that it's supposed to. The kidneys filter the urine or filter the fluids, the urine is developed, the bladder holds it and is supposed to release it once it gets full. But that fullness is a signal that goes from the nerves in the bladder up to the brain that says, hey, we have to empty our bladder now. Okay, it's not something that we cognitively think about because that nerve communication just happens. But with spina bifida, that neurogenic bladder, the nerves in the bladder are not able to communicate, don't get that sensation of fullness. So the body doesn't know I need to empty my bladder. Okay, that's the connection to the UTI, because we have this full bladder, stagnant urine just sitting there. Body doesn't get that signal. So it's not just a matter of I'm full, I know I need to release it. That just doesn't happen. So what these children end up getting is intermittent catheterized to drain that bladder if it's unable to do it on its own. Okay. Wound development can also be an issue, especially in that area, because our nerves are affected. The child may not realize that they're putting too much pressure, or may not know to change the position. So when we talk about our parental education, that's one of our big points there, especially when that child doesn't have the developmental capacity to know that he needs to change his movement. It all has to come from the parents or caregivers. Okay. Other types of neural tube defects that we need to be familiar with. That meningocele looks a lot like that spina bifida. It is a visible sac that we can see, and it contains our CSF and our meninges. Okay, that myelomeningocele is a more advanced case, similar to that spina bifida, and now we have CSF, meninges, and nerves. Myelomeningocele is more likely to have long-term effects, especially related to our mobility. And again, the higher the defect, the worse it can be. The big difference between these meningoceles and spina bifida is spina bifida happens at the base of the spine. Meningocele and myelomeningocele can happen anywhere along the spinal column. Okay, and again, the higher the defect, the worse prognosis, the harder it's going to be on that body as far as development, both physically and mentally. Okay. Spina bifida occulta we talked about, and anencephaly briefly talked on, but that is when we have the absence of both cerebral hemispheres. So essentially our brain, specifically our cerebellum, is missing. There's no treatment or cure for this one. These patients are they're going to be on palliative care. I've unfortunately taken care of several anencephalic babies. All of them are very devastating. This is something that we can see early on in utero. Some women decide to terminate, and of course that is their right. Some women want to carry these babies through. They may feel that they need that opportunity to hold this baby, to have that closure. I've also seen the other side where parents are waiting for that miracle that unfortunately is not going to come with this situation. It's not compatible with life. These babies are not going to go home. Typically, they die within just a few hours. The most devastating cases I've seen are the ones that didn't have prenatal care for whatever reason, didn't get ultrasounds. They thought they had a healthy pregnancy. They delivered and they had an anencephalic baby. Didn't really have that opportunity to grieve. Yes, so the difference between spina bifida and meningocele or myelomeningocele can happen anywhere on the spinal column. Spina bifida happens specifically at the termination, the end point of the spinal column, only at the base of the spine. That's the biggest difference. They present very similarly. You're welcome, Stella. So anencephalic, the only thing that we can do for those babies is palliative care. All right. The last thing that we're going to cover in this section is muscular dystrophy. There are many types of muscular dystrophy. We're going to focus just on DMD or Duchenne's muscular dystrophy. Okay, just like we see with some of these other disorders, we can't diagnose it early in life. Typically, it peaks around 3 to 7. If you think about what children are doing in that age, by this point, according to our milestones, we've been able to learn to walk. We're probably running, climbing. A lot of these children meet all of those early milestones. This is something that happens later on, kind of a debilitating gradual decline of our muscle development, and atrophy really sets in. So these children go from walking to maybe starting to have a limp as those muscles start to atrophy, and then it gets to where they're not able to move at all. Unfortunately, there's no cure for muscular dystrophy, especially for that DMD. We can use prednisone, that steroid, to decrease the progression of weakness, but eventually this is something that is going to fully take over. If we're looking at muscle weakness, the one that we're going to note that's related to our prognosis is the paralysis of that diaphragm. Okay. Once that occurs, the baby or the child rather would not be able to breathe on his own. What happens after that is really up to the caregivers and the healthcare team. This could be a opportunity for passionate hospice care, to allow that baby to just, or that child, I keep saying baby, he would be a child, to allow that child to go on his own, or they can prolong life. That really just becomes a decision amongst the healthcare team. It's not something that's going to get better. There's not a cure at this time. There's a lot of research going into this, but there's not a cure. Okay. What we need to include in our education for the parents is genetic counseling. Should they decide to have other children after this one, this is X-linked recessive, so it is potentially something that could happen again. Okay. So hopefully the research will continue to progress and something will come of this. But at this point, there's nothing we can do. It's really just a matter of waiting out the progression of that. We can try to slow it down. Physical therapy can help a little bit, but eventually a child's going to lose mobility and it will progress. All right, that's the end of neuro. Any questions about that before we move on to our next one?
So the BP shunt, we just need to kind of remember how to maintain it and how to educate the parents about looking out for signs, symptoms of intracranial pressure at home, right?
Yeah. Yeah, thinking about those two big complications, infection and core malfunction or shunt malfunction. And what you would see in shunt malfunction is all those same signs of increasing ICP. Yeah. Any other questions? All right, we're going to go on to Unit 11, and we're going to start with endocrine. There's 3 sections, 3 PowerPoints in this section, kind of just trying to put the rest of it all together. These are short sections, should be able to get through, I think, at least 2 of them, and then we'll finish it up tomorrow. All right, the first thing that we're going to talk about with endocrine is PKU. All right, this is something that you talked about a little bit with newborn. We've talked about it a little bit as well. We're going to go just a little bit deeper into it This is overall, we're in chapter 47, but PKU is actually covered in chapter 25. Okay, so this is one of those early things that we test for on that newborn screen. A lot of nurses will erroneously call that newborn screen the PKU, because when we first developed that newborn screen, this was one of the biggest things that we were looking for. We wanted to identify that a child had this, because it is tied to long-term cognitive and developmental dysfunction. We wanted to identify it early on, make the changes that we needed to, so that the child didn't have permanent dysfunction. So it was one of the early things that we were testing for on that newborn screen. So a lot of nurses will just call it the PKU, even though we test for like 57 other things in this state. Okay. So what we're looking at here, it's a metabolic disorder. The body fails to convert phenylalanine to tyrosine. So the big treatment change that we have to make for these children is that they need a phenylalanine-free diet. Okay. Early manifestation. So hopefully we caught it on that newborn screen, right? It's congenital disorder, so it's something that we should have seen at that point. If we don't catch it, if, let's say child was born at home and never had that newborn screen, or let's say we did the newborn screen, we had that early sign, that early blood work that said we had a potential risk for PKU. We called the parents, we told them, oh, we need you to come in, we need you to get some follow-up lab work, and they never came in. We didn't have that definitive diagnosis, then maybe they would present with failure to thrive. They're not, because of whatever they're eating, if they're on formula, unless it's a phenylalanine-free formula, or if they're on breast milk, which is low in phenylalanine, but not phenylalanine-free, we may have those issues in the body, okay? So failure to thrive, vomiting frequently because they're not able to digest, irritability, hyperactivity, erratic behavior. The irritability and hyperactivity, we're starting to see that change in the neurologic function. Erratic behavior, we're already at permanent brain dysfunction there. Okay, so the pattern for the normal child born in the hospital, doing, mom's following all of the recommendations. If that first newborn screen is positive, right? So we do one about 36 to 48 hours, something like that, 36, 72, sometime before discharge. If it's positive for PKU, then we do the plasma test, right? So they come back into the pediatrician draws this lab. Now we have definitive diagnosis that it's PKU. So a positive newborn screen does not say definitive PKU. The positive newborn screen, whether we're talking about PKU, congenital hypothyroidism, any of them, is just red flag. We need more testing. Okay. Could it have been contaminated? Could it have been mistested? Could it have been an error in sampling? Blah, blah, blah. Absolutely. That's why we come back in as soon as possible to get retested. All right. The mom says, I can come in 2 weeks. No, ma'am, that's too long. I need you to come tomorrow. Right. The sooner we can get that confirmatory test, the sooner we change the diet, the sooner that we have the ability to have a better prognosis for that patient. Does that make sense? So diagnose early treatment, better prognosis. Okay. All right, so our treatment here, this is a lifelong condition. This is not something that the baby is going to grow out of. Very important for that child to understand. So lifelong modification is a diet low in phenylalanine. All right. If mom wants to breastfeed, it is possible that she can. All right. I said breast milk is low in phenylalanine. If she wants to exclusively breastfeed, we're going to have to monitor that child's phenylalanine levels very closely. All right. What is most likely going to happen is that she's going to have to breastfeed, but also do a mix of low phenylalanine formula to help keep that phenylalanine in the body. God, that's a hard word. Keep that level low in the body. All right. So the healthcare team would decide on the best type of treatment for her, for that child based on how she wants to feed. Okay. other things that we have to, and this next point is really important for you guys to get. Meats, eggs, and dairy products are eliminated. I mean, it's not something we have to think of from the minute that child is born, but as we start to introduce foods between 4 and 6 weeks, no meats, no eggs, no dairy products. All right. All of those are high in phenylalanine and would cause issues for this baby. Okay. So things like vegetables, fruits, cereals, all of those are going to be great for the child. As he gets older, there's other things that we can add into that, but early on, meats, eggs, and dairy off the list. Okay. As we continue to monitor those levels, we may have to add in some tyrosine supplementation as well. All right. You see back on this, this first slide, the whole pathology here is that the body can't really, do anything with that phenylalanine. It is supposed to, as that metabolic pattern happens in the body, it's supposed to take that phenylalanine from whatever food's been ingested and convert it to tyrosine. All right. Because we're not giving the body that opportunity because it can't do this process correctly. Now we're at the point of potentially having tyrosine, low levels of tyrosine. So we may have to supplement that as well. Okay. So very important for you guys to understand as far as the diet, things that we can and cannot have. All right. Big focus of this next exam for you guys is about parental education. So looking at what you would tell your parents, what the child can eat as he gets older, what he cannot eat, very important. Okay. All right, the next condition we're going to talk about is precocious puberty. Precocious means that it's like an early thing. Someone has a high level or interest in something that's really beyond them. So essentially what's happening here is that the child is going through puberty earlier than he really should. Okay, so we see this in age 9 in boys and 8 in girls. All right. This typically is connected to other congenital abnormalities. All right. There's typically not something that we are going to see when this baby is born, but there are other issues, other chromosomal or other physical issues, spectrum disorders that usually are connected with this. It can occur by itself as well. Okay. So if we see, can be secondary to CNS trauma or can occur idiopathic, that's just a primary. We don't know why it happened. It just happened. Okay. The manifestations, if you look at these are all the signs of a child going through puberty. It's really just about that timing. It's too early. That's what makes it precocious. Okay. Too early for that. So what are we going to do about it? All right. Depending on when it happens, we may choose to not do anything about it. We may just let nature happen. We may decide that we want to slow the progression of puberty, and we can give some hormones to make that happen. Okay, so we'll give that LH or that luteinizing hormone as a monthly injection to prevent the other puberty hormones from taking over. All right. This just delays things so that this child doesn't have to go through puberty earlier than the rest of his classmates. If we think about where he's headed with Erickson or where she's headed with Erickson, doing things that are not what the rest of your peers are doing could be developmentally damaging. This is the biggest reason. There's not really a physiologic reason that we need to treat these children. Okay. It's more about, from a developmental standpoint, trying to keep them at a point where they're with the rest of their peers. Okay. So when we know if it's secondary, if we're having precocious puberty secondary to a trauma, secondary to something with the CNS, obviously the first thing is to figure out what that cause is, that primary cause is, and treat that cause. It may be able to, if we treat that cause, it may lessen these effects, kind of may dial back this early development of puberty. All right. The next question really becomes, I mean, this isn't a lifelong thing, right? Puberty is something that happens once in our lives. So we aim our treatment at really just prolonging how long we want for puberty to happen. Okay, so family and healthcare team are going to come up with a plan. If they do decide to treat, maybe they treat, for a year or so until some of the peers of that child are starting to have these early signs as well. Again, the whole point is we want this child to not be affected from a developmental standpoint. We don't want them to feel like they are outside the rest of their peer group, knowing where they're at with that development. Okay. When we are providing, whether we give the hormones or not, the other thing that we want to keep in mind, most of the time that we're talking about what we do for children, we talk about it from a developmental age standpoint. For this, when we're talking about how to dress the child, how to treat the child, we want to come at it from a chronological. We focus a little bit more on that age because developmentally, if we've decided not to treat it developmentally, they may look older, all right? They may look like they're 12 when they're actually only 9. We want to continue to dress them or address them like they're 9. Okay, so that chronological age becomes a big factor here, not something that we often have as a sticking point here, but we want to keep them in that chronological age, again, because we're trying to keep them with their peers. Okay, so biggest focus here is really just trying to keep them looking like their peers so they still have that acceptance so that it doesn't affect them from a developmental standpoint. Does that make sense? All right. The next thing that we're going to talk about is juvenile hypothyroidism. Congenital hypothyroidism is something that we can test for on our newborn screen. All right. Sometimes that is going to come out normal because we still have mom's hormones in our body. All right. Sometimes it can take a little time before the baby's hormones, we have that big switch from fetal circulation into newborn circulation. It's very similar to that. So mom's hormones, mom's thyroid hormones may actually cross that placenta, be in that baby system to the point that we don't see at that first newborn screen, we don't even see it at the 2-week newborn screen that there's an issue with our thyroid hormones, okay? Sometimes that child can actually compensate up to like 1 to 2 years of age with his thyroid levels that we still haven't known it or noticed it. We don't see any symptoms. Okay. The big issue with congenital hypothyroidism, just like we talked about at that PKU, is that potential for developmental and neurologic capabilities. Okay. So we want to look for those early signs, which we'll talk about in just a second, but sometimes the body can compensate. So it can still be a case of congenital hypothyroidism that we don't diagnose until 2 because the body's able to compensate up to a point. Sometimes when we start hitting those big growth milestones beyond that first year, that's where the body is like, wait, I can't do this anymore. Okay. We can also have hypothyroidism that is acquired, something that develops later in life, can be secondary to a disease process that has happened or treatment. If we had thyroid cancer that we noticed in our baby, typically not a very common thing that happens in our pediatric population, but it can be secondary. Okay. So when we're looking at the side effects here, very similar to what we see in our older adult. We see that intolerance to cold, receding hairline. We see facial edema, especially that periorbital. They may show extreme fatigue, brittle hair and nails, anorexia, just really not that that desire to eat, lethargy, dry skin, again, all the same things that we see in our adult population, okay? If we see this develop in post-puberty, especially in our females, we may see some of those menstrual disturbances that, again, that we see in our adult population, okay? So we look at those manifestations. Some of the other things that we're going to see, decelerated growth. These children are going to have in that first year, grown appropriately, birth weight doubles at 6 months, etc. They meet all of those milestones. And then as their body is getting to where they can't compensate for those levels anymore, it's where we start to see a sudden decline, right? So maybe they went in for their 18-month well check and everything was moving along perfectly. They're growing effectively. They come back in at 2 years, so 6 months later, and they haven't grown at all, right? And maybe all the milestones that they were supposed to have meet from 18 months on to 24 months, maybe they didn't meet any of them. Now we have a cause for concern, something that we want to look at, because we're not just a couple weeks behind, we're 6 months behind and we didn't have any growth. The biggest thing is going to be about that lack of growth, because it does slow down at this point, but to not have grown at all in the next 6 months, that's going to be something that's really concerning. All right. So how do we detect this? The same way we do in adults. We do some serum levels. We see that they are not where they're supposed to be. How do we treat it? Same way we do it in adults, right? We give that thyroid hormone replacement. Important things to keep in mind: give on an empty stomach. We do have to monitor those levels just like we do in our adult. Make sure we're in that therapeutic level. We don't want to go too much or too little, because then we're not doing anything helpful for that child, okay? If we were to diagnose this when we were dealing with an infant, it came back positive on the newborn screen, that child goes in for follow-up serology testing, and it is confirmed that this child has congenital hypothyroidism, our treatment is the same. We just have to think about how we're going to do this for the baby, okay? The medications that we provide, that thyroid hormone replacement, can actually crush this and then put it just in a small amount of milk, whether it's formula or breast milk. We do want that child to drink that concoction first, the thyroid hormone replacement crushed in with that milk. We want him to drink that first. 5 mils is probably all he needs in that. And then that mom or caregiver can carry on with however else we're feeding this child. If the mom wants to breastfeed, something that's still completely possible here, and give that medication, again, on the empty stomach. So that's another good reason why it has to be first. The other factor is, if we give it first before we do the rest of the feeding, we can ensure that that child is going to take everything. Okay. Any questions about that? No. All right. The next thing we're going to talk about is diabetes. All right. This is a big conversation. When it comes to diabetes, we'll talk about some specifics from type 1, but a lot of this is going to be a repeat from what you've heard in your other classes. Okay. So we have 2 different types. Essentially, we've got type 1 diabetes. That is our insulin dependent. When we talk about juvenile diabetes, that's essentially what we're talking about here. All right. Insulin dependent means that the body just is not able to process that. All right. With type 2, we have insulin resistant. Essentially, the body's making too much insulin because of all of the additional the factors, right? We know that type 2 is often secondary to obesity, overconsumption of certain products. But we're just really not able to effectively utilize the insulin. Okay. This used to be just a problem that we saw in our late middle age and chronic, or our late middle age and elderly, but we know this is starting much younger, and we actually are having children diagnosed with type 2 because of the problems with obesity in our country. Okay. So when most often in our pediatric population, when we have children that are diagnosed with diabetes, most often it's type 1, but that's not a 100% rule anymore. Okay. All right. If you look at page, where is it? It's page 1408 in the 7th edition, 1434 if you have the 8th edition. We look at the big differences between type 1 and type 2, but understanding that type 1 is insulin dependent and type 2 is insulin resistant will be really helpful in helping you distinguish between those two. Okay. All right, so when we look at the pathophysiology, we've got a deficiency of insulin. Glucose is unable to enter into the cell. That is what results in our hyperglycemia. We think about our 3 Ps of hyperglycemia when we're making these diagnoses. So polyuria, polydipsia, polyphagia. These children are very hungry, very thirsty, and they go to the bathroom all the time. Those are our 3 Ps when we're looking at hyperglycemia. When we're looking at early diagnosis is often where it comes from. We have parents or caregivers that are reporting these things. We look at what happens from a clinical standpoint. A lot of children don't get their first diagnosis with diabetes until they've gone into a crisis, which is unfortunate. But I mean, we don't really have a good way of testing early on. There's not a routine test that we could do that would be effective in really highlighting this until we're really seeing those risk factors. Okay. So in my clinical experience, a lot of children are not diagnosed until they have something like DKA. They go into some of those crazy situations because the parents weren't really educated or didn't really see those early signs, those 3 Ps of the hyperglycemia. They were just kind of chalked up to normal childhood. And it wasn't something that the pediatrician picked up on or anything like that. So it's not until we get into that complication that we really start to see whole picture. And then we can look back and pinpoint, oh, well, that makes sense. I can see that from what that parent reported, but it can be really difficult to make that first diagnosis or to really understand that that's what's going on until we see some of those advanced situations, because it can be very subtle in our pediatric population. Okay. All right, we diagnose this the same way that we do in our adult population. We look at that fasting glucose. So this means that that child hasn't had anything to eat, over 126, a random glucose over 200, that A1C over 6.5. I think all of those numbers are, if they're not the same as adult, they're very similar. No big changes there, but we have that same diagnostic process there, same treatment process as well. The big difference that we have to look at here is, are we treating type 1 or are we treating type 2? There can be some differences there. I do want you to look at the table 4714 on 1410. Or 47.4, 1439 in the new edition. You do need to understand the types of insulin, right? We've got short acting, intermediate acting. I want you to be familiar with those time frames. Okay, as far as when they peak, how long they circulate in the body, you're gonna find that information helpful. I'll just tell you that. Okay, so the treatment is insulin replacement. If we're looking at type 1, we're most likely going to do an insulin pump because it provides a more consistent supply of that insulin. You don't have to prick yourself. They have so many fancy things now where you actually, it's able, the pump is able to tell, or there's a thing up here that tells you what your blood sugar is. You can do it from your phone, or there's a little machine that will read it. Your pump is able to give the insulin that you need to do. So they're making it a way where it's less painful. The whole idea of that, one, is to make it easier, especially when we're dealing with the pediatric population. But two, the other factor is the less painful it is, the more likely a person is to comply with that treatment. All right. We know that it is way more than just that insulin replacement. There needs to be some dietary changes. A lot of parent education goes into this. We'll go deeper into that in just a second. Okay. We look at our complications of diabetes, hypoglycemia, hyperglycemia, depending on if it's related to the insulin that we've just provided for ourselves or related to behavior. So understanding these symptoms is very important. Table 47.3, 14.2, looking at the differences between hypo. This is one of those things, if you don't have this down yet, I mean, now is as good a time as any, whether it's on your next exam, it's on an exam that comes for you in advanced med surg, it's on NCLEX, etc. Understanding the differences in these signs is very important because it immediately tells you what's going on with your patient and what you need to do about that. So it's very important for you to know these signs for the next exam, but also for further on to your nursing. Okay. Other complications, DKA. This is going to be a very sick child. Most likely, if a child has gotten to this point, we have found him unconscious. He gets brought into the ER. He gets the workup, right? We do his, we get some lab work. Vital signs are probably terrible. That blood sugar is going to be what confirms that we're in a situation of DKA. So we're going to treat him aggressively, but then he's going to spend some time in the PICU while we balance everything out. We're going to follow H&H. We're going to look at his white blood cells. Electrolytes, BUN, ABGs, all of these things are going to be very important. He's going to be on telemetry, frequent vital signs, because even when we get him, that glucose, we get him out of that critical stage of DKA, we're not out of the woods, especially while we're trying to figure all of this out. Okay, we need to rebalance all of his hormones, rebalance all of his electrolytes, and that means that he needs to be in PICU for very close monitoring. Okay, other things that we see, same thing that we see in adult. Not something that we're going to most likely see in our pediatric days, but at some point, especially the earlier that diagnosis, the less pliable they've been with treatment, the more likely we are to see these. I mean, the neuropathy, retinopathy, renal disease, all of those are complications. Even the diabetic that does the best treatment, stays on course, frequent follow-ups and all of that, can still develop these diseases or these complications just because it becomes a vascular issue. Okay. But the hope is that the better the treatment, the child or the patient that is able to stay with the treatment and has a better prognosis if they stay compliant. All right. All right. So we talked about that. This slide just kind of goes through some characteristics of the differences. So abrupt type 1, this is why we typically see these children when it's at a complicated state like that DKA, because the subtle signs were a bit too subtle, and then it just happens like that. All right. Those 3 Ps that we talked about, the polyphasia, the polyuria, the polydipsia, those are very common. These children typically are underweight versus overweight. And then you can see insulin is going to be required here. Oral agents, diet changes only are not going to be effective for type 1. This child needs some consistent insulin, which is why the pump is such a great idea for him. Okay. All right. As far as your education, several things that we want to focus on. We want to think about all the things that we need to share with our parent. That illness management can be a big factor. We know that children with diabetes or people with diabetes in general can get sick more often when they have diabetes, but their illness can also be more advanced just because of how hard the body is working trying to balance that insulin. when a child is sick, whether it's from a viral illness or something more severe like pneumonia, that insulin can go out of whack, right? It can get either too high or too low based on what pathology is going on in the body. So we need to more frequently monitor it than we would if we're not concerned, okay? So we have to watch closely for those signs in hyper and hypoglycemia. We treat those ketones because the child with type 1 can go into DKA related to an illness very quickly. So we follow those. We maintain his hydration. We provide insulin changes as necessary. And then the other education that we want to provide is when it's time to notify the physician. In the child with diabetes, we're more likely to notify the physician based on signs of illness more frequently or earlier on, more aggressively than we would with the child without diabetes. Okay. When we talk about other education, a big factor here becomes that diet. All right. I have seen children from like my clinic side, taking students into the clinic, the clinicals. I have seen children have multiple situations, multiple events of DKA before the family really gets that understanding. Oh, this is a big deal. We need to like make some changes. Part of that is from the family trying to or expecting the child to be able to make those changes on his own. Families that see the most positive effects or see the child, especially that adolescent or that pre-adolescent who wants to be accepted by his peers, see them make the best decisions when it comes to food, it's when everybody in the house is doing it. So most successful changes in these dietary habits in our children happen when the whole family is on board with these changes. All right. Things that we have to take into consideration with our diet: adequate intake. We already said that children with type 1 are likely to be undernourished. So this is a factor we have to work on. Consistent menus, consistent feeding times as well. We want to focus on those complex carbs. We want to take the child's preferences into consideration as much as possible so that he's willing to eat whatever it is that he needs to eat. All right. Cultural needs may also have to be put into consideration. Let's see, any other. So as far as insulin administration, we don't typically just put in that pump. We kind of we work up to that. So typically we start with those SQ injections, just like we see in type 2. Depending on how old the child is, most children are diagnosed between 10 and 14, but sometimes it does happen younger. So the younger the child is, the more involved that parent and healthcare team is going to have to be when it comes to managing the needs of this child, because developmentally and cognitively, he's just not capable of doing it. Okay. Exercise is something that we need to keep in mind. We want the child to regularly exercise, but we do want him to understand, depending on what type of exercise, the more aggressive he gets with his behaviors, the more likely he is to experience hypoglycemia. So he needs to have some of those complex carb snackers, peanut butter crackers or something like that, to help boost that up. Signs and symptoms we talked about: scheduled time for meals and snacks, keep that insulin level at his baseline. As the child gets older, as we move into pre-adolescent, into adolescence, I mean, this is a lifelong thing that this child is going to have to live with. So letting him start to take control when he shows signs, and sometimes it can happen in school-age children. You know, every child matures a little differently. Sometimes chronic illnesses make children mature a little faster in general. So that may be something that we're able to do earlier rather than later. But we want him to start taking ownership and accountability of management of his diagnosis, because it's something that he's going to have to deal with for the rest of his life. Okay. The worst thing that a parent or caregiver can do is to be overly involved, especially as that child matures, because it's going to be a lot harder for him to take over care as he gets older. All right. I do want to point out, I provided those practice quizzes for you from Elsevier. Some of it, I tried to weed out the content that didn't impact you as much as possible, but it was a lot of back and forth between different screens, and I was trying really hard to not make any mistakes as far as the questions that I posted and then the answers and all of that. So if you find that there's things that we're not talking about in class that aren't covered in your PowerPoints, don't spend as much time looking at that content. Try to focus on what we cover in here, because this is what's going to be on your exams. Okay. Anybody have any questions about the endocrine section?
What table or box did you say we should look at for the?
Oh, yeah.
Yeah.
So if you're looking at the differences in type 1 and type 2, that's page 1408, table 47-2. Does everybody have the 7th edition? I'm going to go with yes. So that's page 1408, table 47-2. And then if you look at table 47-4 on 1412, that table is about the differences between hyper and hypo. And then when I talked about the types of insulin, table 47-14 on 1410, that talks about your types of insulin, where you can be familiar with the peak time and the effects in the body. That'll be helpful as well. Okay, I have talked for a long time. You guys want to take a short break and then we'll come back and do integumentary? Yeah. All right, let's take we'll take an 8-minute break. We'll come back at 8:50.
Okay.
Thank you. All right, let's see how far we get with integumentary, and then we'll finish tomorrow if we need to. All right, so let's talk about some of our differences in children. We've started several of our sections like that. We do see blisters more easily in our children. The skin is more fragile. Part of that is because it's thinner. It doesn't have that same protection that we've built up over years of time. Can also be more susceptible to bacterial infection. Could be part of that protection. Our skin is our first line of defense when it comes to protection from pathogens entering the body. All right, so if we see that it's thinner, there's more likely to have those breaks in it that allow those pathogens to get in. And because the overall immune system is not as strong as we see in our adults, we have a higher likelihood of it causing an issue. We also don't have the same level of control in our children when it comes to washing our hands, preventing, infection passing from scratching. We see those higher incidents of infection in our children because they do have that greater exposure, whether they're in daycare or in the school environment or something like that. They're also more impacted by atopic dermatitis or eczema. We'll talk about that condition in just a second. And then they're just more sensitive. They just haven't had as much time to be exposed to things. I see sometimes little rashes, little hives that come up on my child's skin right there. And it's just an exposure to something that he hasn't been exposed to, whether it's, a stuffed animal he rubs himself against or something like that. His skin is just sensitive. So it has that kind of fighting process that it does. All of that increases the likelihood of having a skin issue, whether we're talking about an infection or otherwise. All right. So how are we going to diagnose this? We want to ask the child if he's able to communicate with us or the caregiver about pruritus, itching. Itching is a big is very helpful when we're looking at trying to diagnose what's going on with the skin. If it's causing itching, that typically means that there's some type of allergic reaction that's happening. So that can be helpful. Pain or tenderness, stinging, if the child can describe it, if it is causing pain, or if there's a certain sensation that he's feeling, that may also help us kind of diagnose or start to look towards what may be causing the issue on the skin that we're seeing. Okay. Alterations in local feeling, onset, especially if we can pinpoint, was he outside? Did he roll in the grass? You know, the more information we can get while taking that history is going to help us determine what's going on. All right. Other things that we're going to do for our assessment, of course, we're going to look at the skin. If we note a rash, we want to describe that. Going back to things that you guys have probably covered in med-surg or other classes, how that rash presents, what it's looking like, those factors, is it weeping, etc. All of that's going to help us determine what's going on here. Okay. Also want to look, is this a primary, it occurred on its own, or is it secondary? There's certain things that happen. Some of our communicable diseases, for example, cause irritation or situations on our skin that help us point to, I know looking at that is the measles rash. I know looking at that that's varicella. So there may be things that we're able to tell about the skin by the way that it looks. So it's important to document and really identify that. All right. As far as lab findings that would be helpful, blood work, looking at our CBC may help us, especially that white blood cell may tell us if there's an infection going on. That ESR, that erythrocyte sedimentation rate, helps us look at inflammation. They may be helpful in certain systemic diseases. We may also want to send a skin scraping, or send, if we've got vesicles or any type of drainage in our skin situation that's going on, we may also want to send that off to micro so they can do some more testing. If we're thinking that we may have an allergic reaction going on, but the parents or caregivers aren't really sure what's causing it, a allergy skin test may be helpful. This allergy skin testing isn't something that we just jump to when it comes to children, because one, it's very irritating. For those of you that have had one, I can remember mine. It was a pretty miserable week, because your skin is introduced to things that are known to cause irritation or allergic responses, and you're not able to take anything or put anything on it that would make you feel better, because the whole purpose is to see what exposures cause you problems. It's hard for a child to understand that. So not always a great thing to do. But if we're having difficulty trying to figure out, if parents have gone through trying to remove things, they've changed, the soaps they're using in the house, or whatever it may be, and we're still not able to come up with why that child is having an allergic reaction, it may be helpful to do the skin testing. Okay. All right, so now we'll talk about some specific conditions. So impetigo is the first thing that we want to talk about. It is important to note that impetigo is very, I repeat, very contagious. Okay, so you can see it often happens on the face, but it can happen anywhere. It's a bacterial skin infection. It starts as that red macule that you're seeing kind of here at the crest of the mouth. And then it turns into a vesicle, which is a fluid-filled macule, a fluid-filled bump, and then it ruptures very easily. Once it ruptures, the liquid that comes out of it, that is what is contagious. Okay, so we see once it has ruptured, it provides these honey-colored crusts that we're seeing. You can see them in both pictures. That is the part that's contagious up until when it crusts over. Okay. So what do we do for these children? We're going to remove those crusts. We're going to do topical antibiotics. Because it's a strep infection, we can also give penicillin unless there's an allergy. We also want to prevent infection, which means frequent hand washing. We also want to separate this child until everything has started to heal. at least until everything has crusted over, because when it's open and oozing, that's when he is the most contagious. Okay. The next thing we talk about is acne. Most of us have probably had some effects of acne, whether it was just a couple zits here and there when we were going through puberty. For a lot of us, especially females, it's very hormone balanced. So unfortunately, I still get a few pimples here and there, depending on what time of the month it is. For most of us, it's not that big of a deal. It's a little unsightly. Maybe we wear some extra makeup or whatever, but it doesn't cause most of us a lot of issues. For those that do have some advanced cases, what we're seeing in this picture, this is acne, cystic acne, essentially. Some children or some teenagers get it a lot more aggressively. There's thought to be a genetic component here, but it can be something that just is related to unbalanced hormones. Okay. Testosterone is a big factor. So we definitely see this in our male patients. Overall, I mean, it's not physically causing any harm. There may be some potential scars, especially if we have people that pick at them. But again, if we look at it from a developmental standpoint, this is something that could push a child outside his peer group, make him or her feel unaccepted. And that's really that biggest impact there. So a lot of parents or caregivers will seek to get treatment through the dermatologist, mostly because of how it's impacting that child from how they feel about themselves. Okay. Sometimes a healthier lifestyle, proper hygiene, frequently washing your face, not over, scrubbing your face is actually going to make it worse. Using too many products can also make it worse. So there, for a lot of acne, there are certain some hygiene things that we can do. When we get to the point that we're seeing in the picture, this is not related to hygiene anymore. Okay, this is something that we may need some more aggressive treatment here. This is where the dermatologist would likely be beneficial. So we can do that retina A, that Accutane. Accutane, we do have to be very careful with, especially with our female population. This is one of those things that has teratogenic effects. Should this teenager get pregnant, it can cause a lot of issues there. Antibiotic therapy can be helpful as well, depending on what the cause is. If we're noting that if we send off something to micro and we note that there's an infection there, that may be something that's helpful. For most people, this is just something that's going to run its course, right? It's typically something that once puberty kind of slows down, this is going to slow down as well. All right, the next thing we have to talk about is lice. This one always makes me a little squeamish. So not something I have a lot of clinical experience with, but this is a parasitic infection, something that's very common in childhood because it is so easily spreadable. It is important to note that lice do not jump or fly. So if I'm sitting next to a person that has lice, that lice is not just going to jump into my hair. I have to share a hat. I have to use his brush, something like that, to get those lice into my hair. They're not going to jump to me. All right. Biggest thing that we see, biggest red flag is children walking around doing this. That scratching is a big red flag, because when these lice attack and start to dig into the head, they are very itchy. Okay. Diagnosis is made by, you can see these nits, these eggs there. Sometimes you can see the lice themselves in the hair. We're going to use pediculicides to remove that. Permethrin cream rinse, that Nix, that's something that I see some of you scratching your heads right now. That Nix is something that we can buy over the counter. That's something that we can do. If we have a more aggressive condition of lice, we may need something that's by prescription, but typically that Nix is going to get it. Things that we do want to keep in mind. So we'll do that treatment, and then about a week to 10 days later, we're going to repeat that treatment just to make sure that we got any eggs that may have been left behind. We also want to make sure that we're cleaning anything that lice could have like connected to, the child's pillows, his blankets. If he laid on your pillow, then you need to wash that as well. We don't have to throw things out. We just have to wash them in really hot water to make sure that we kill those little buggers. Okay. Any personal items, brushes, that kind of thing, we can clean those with bleach, something that's definitely going to kill those. I think I would be of the mindset, if and when this happens to me, that I would want to throw things out. But just know that you don't have to throw things out if you have a way that you're going to be able to clean them. Hot water, like running it through the washing machine, usually is effective enough. Okay. All right. So the next thing we're going to talk about is dermatitis. Often, I mean, this is an inflammatory reaction. It's typically related to some type of allergen. Something that can happen just one time exposure, but can get worse the more that we have that exposure. Okay. The biggest goal here is to determine what caused our inflammatory response and remove it. All right. There's a big genetic component here. I've noticed this, like I have very sensitive skin. There's a lot of things that I'm allergic to. I have to be very careful with the soaps that I use as far as laundry detergent and that kind of thing. My son, I mean, all babies have sensitive skin in that first couple of months, but I've noticed that he is my sensitive skin. Like I have to be very careful with the sunscreen that I use. Any lotion, I mean, lotion just in general is not very good for him. He's had a response to almost every type of lotion that I've tried to use. He's good with Johnson & Johnson, but that's about it. So we have to be really careful. So there's definitely a genetic component there as well. We can see it, it's often with that chemical. I mean, there's a lot of things that we make that have made our lives easier, but because they're not a natural product, we tend to have some reactions there. Okay. Can happen from natural. I mean, you can have an inflammatory response from grass. There's a lot of components that go into it. All right. So as you're seeing in that picture, what we have is that sharp delineation. This means that this doesn't happen as kind of a generalized exposure. It happens specifically where that skin came in contact with that item. Okay. Typically itching can be very painful. Often the more we scratch, the more painful it gets. Okay. Mild cases, we can do topical steroids. There are things like cortisone cream that we can get over the counter that's going to be helpful for a lot of these cases. If we're having a more moderate reaction, we may need some stronger topical medications that we need a prescription for. And then if it's severe, I would call this case in the picture, that's very angry looking. We may need to do systemic corticosteroids because it's an inflammatory response. Having that fully in our system may help. Okay. We're going to talk about a few other types of dermatitis. This poor baby. This is diaper dermatitis. So this is something specifically that happens to children that are wearing a diaper. Can be related to poor hygiene, not changing that diaper frequently enough, can be related to just that very sensitive skin inside that diaper. Some wipes, some diapers have heavy perfume. So using something that's hypoallergenic can be helpful. We see again those sharply demarcated edges, specifically in the folds where fluid or that wetness has an ability to get in, and then we have that skin on skin contact. Okay, can see secondary infections such as Candida or yeast in that area. Just that bacterial growth in that area has that way of kind of shutting down the immune response and allowing things like yeast to thrive. All right. When it comes to our treatment, we want to keep the skin dry. Super absorbent diapers, changed frequently, can also leave this open to air whenever possible. This is something that we have to do a lot in the NICU because our sensitive population is very prone to diaper rashes, even with all of the hypoallergenic things that we do in the unit. So we can leave them open to air. You go back to that picture that we had with that spina bifida where that baby was just laying on the diaper. That's something that we often do, kind of put that chucks up around his bed to protect everything. But the drier we can keep that area, the faster it's going to heal. Okay. Zinc oxide is your standard Desitin ointment, as long as the skin is not broken. We don't want to use zinc if the skin is broken, because that is going to burn. Okay. We also don't want to overwash. The more we scrub, the more aggressive we are, we're just breaking that skin more. So we wipe very gently. If there's stool, we have to get it off. Otherwise, that's an infection risk. Okay. But we want to use wipes. If we're seeing something like this, we may want to just use water wipes. Just take some basic 4x4s, use, tap water and use that, because there's no chemicals in that. That may be helpful. The goal is to avoid further irritation through our cleaning manners. Okay. Atopic dermatitis, also called eczema, is a very strong genetic predisposition here. So there's typically a family history, but they may also have asthma, food allergies, other allergic processes that are going on, that they just have that heightened allergic response. Okay. Just like our goal with basic dermatitis, we want to figure out what that allergen is and try to remove that from the environment. Okay. We do see this be worse in the winter months as that skin gets drier. So there's a lot of preventative lotions with and without steroids that may be helpful. The more hydrated that skin is, the less likely we are to have an eczema attack. Okay, relieve the pruritus. We don't want the skin to itch, especially in our pediatric population. It's really hard for them to control the itching. And we know that itching often is tied to a secondary infection related to that scratching. All right. We may not have cleaned our hands before we scratch, and whatever is on our hands may now get inside our skin, cause a bigger factor. We may have just had our hands inside our diaper, who knows where our hands were, and now we're scratching, breaking that skin, and that pathogen can get directly into our system that way. Okay. All right. So treatment, like I said, avoid exposure. If we figure it out, we want to try to remove it. Antihistamines, a lot of people with eczema will take a daily antihistamine just to keep everything at a low level. Topical immunomodulators may be helpful, especially if we have advanced cases. Topical steroids, we want to do a thin layer. Notice that is bolded and underlined. Right? You should read that as important. Thin layer, it is a steroid. It is not something that we want to cake on. The more we put on, it's not going to be any more effective. So a thin layer is plenty. Mild sedatives, especially if we can't get that child to stop itching, and antibiotics if we do cause a secondary infection. Right. We'll stop right there. We'll pick up with animal bites tomorrow. Just a couple slides left here, but I want to be courteous of your time. You guys have any questions before y'all jump off for today? No? All right, we'll pick up with animal bites tomorrow, just a couple more slides in here, and then we have musculoskeletal, and then we'll start our review. All right. You guys have a great day. I'll see you tomorrow.
You too. Bye.